I see it's 5 o'clock. I'll call the Health and Human Services Board to order on October 18th. Roll call, please.
Julie Smith. Present. Lisa Lind.
Present.
Sean Anderson.
Present.
Kathy Leaf.
Present.
Dave Osnes.
He's excused.
Greg Telejohn.
Present.
Mike Barkalow.
Present.
Deb Lindeman.
Present.
Dr. Anwar.
We have a quorum. Hearing no objections to the minutes that were presented, they'll stand approved. Anybody have any objections or changes or corrections? No, their minutes are approved from Wednesday, September 20th. Any public comment? Any public comment? Any public comment? No. Business items, Health and Human Services monthly financials.
Thank you. September financials were included in your packet. These are through September of 2023. Just a couple of things to point out for you. If we go to behavioral health, one of the line items for medical supplies, it's like 2,616% over budget. That was supplies we bought with our state opioid response grant. So it wasn't initially something we had budgeted for, but we had funding available. And so we were able to purchase some supplies to use for clients and then for some of the Narcan and other items that SHAR has available for people. Within Children's Services, I just met with them today and we were doing a review of their purchase services. As we've talked about before, our out-of-home placements are high and we have some very expensive placements, but we also within our birth to 3 department are doing more contracted services. We have a couple of positions that were open and we have not been able to fill, so we're contracting for those speech therapy services. So that will continue to go up. We do bill for that, so we do get additional revenue back as we bill for those services. That's all I really had on the health and on the human services side. Are there any questions for that? Okay. When we get to the health center campus, September revenues are not in this amount. It must have been the timing of when our September revenues were posted and when the report was printed. So there's $340-some thousand that's not included in here. So once that's in there, the health center campus as a whole is showing a positive balance. There's a couple journal entries as we're getting towards the end of the year. We're doing a lot of reconciliations, so there's some accounting expenses to move from human services back to nursing home. That will affect that, but that's a pretty minimal amount. Any questions for me? Okay.
Doesn't look like it. Thank you.
Thank you.
Next item is St. Croix County Community Garden update.
Excuse me. Hello, everybody. My name is Teresa Babbage, and I'm the Public Health Nutrition Manager. And I just wanted to share with you for a few minutes tonight about a really excellent collaboration between our Public Health Department and the community. And I think, oh yeah, there's some info. There is going to be a slide that's going to talk about some of the produce that we've provided. But just to give you a little bit of background, in 2015, myself and a couple other members of our public health department put in a community garden. Actually, our facilities, I believe, tilled it. They were 4 little square gardens. And our purpose was to try to get more produce, fresh produce available for the community. That same year, we also worked with local farmers market to put a farmers market in our in our parking lot at the services center. Unfortunately, despite, pretty much walking WIC clients out there with their vouchers, we just didn't get enough utilization of that market for it to be viable for the farmers. So we only had that market for 1 year. So at the same time we were thinking about, okay, now what do? We are fortunate that our public health supervisor at the time, Sharon Razor, was part of the St. Croix Valley Master Gardeners. And so she took it to her group to say, hey, would you like to work with public health and help us expand this garden? And, that year was 2016, and it was really a wonderful collaboration that allowed us to expand the garden to more like, I think it's currently like 25 by 25 feet, which isn't that big when you think about the number of, poundage that we yield out of that little garden. So when we brought in the master gardeners, it really allowed us to free up, pretty much prior to that, the public health staff was working, off hours, weeding and doing all these things. I did throw it out to our staff several times that it would be a really good stress reliever. Come after work and weed. I think I had one person take me up on that, and she's sitting in the back of the room. So yeah, that didn't work. So having the master gardeners with their expertise was really a wonderful collaboration. And I want to give you a little bit of background on the Master Gardeners. Their mission is to provide community service through education, environmental stewardship, and to provide information on horticulture to residents of Pierce and St. Croix County. The other interesting thing is they need to volunteer for at least 24 hours and obtain 10 hours of horticultural education. So it was a win-win. They were filling in some of their volunteer hours, so the garden was a great fit. They can apply for different grants, and they received, most years they receive about $250 that they used for seeds and plants, supplies. This year they provided their own soaker hoses, and many of the volunteers really also donate a lot of their own tools when they come up. We no longer have like a little storage shed, so they have their own scale that they measure all the produce, and they bring that all with them. So this year in 2023, 10 volunteers worked a total of 215 hours to maintain that garden. So you can see how our little public health volunteers couldn't quite do that. They planted the garden. Like I said, they used the funds that they had written a grant for to get the seeds. And so really my role is kind of the liaison between what are we going to do with this produce. They coordinate the volunteers, but often they would set the hoses on a timer, and I'm going to go out there and make sure we don't flood the whole back side of the building. And so starting off in 2017 is when we started to really keep really close track of how much we were getting out of that garden. And it was about 400 pounds of produce, and in 2018, we yielded about 562 pounds of produce. And that's where another collaboration came in. Through our community coalition, Healthier Together, over the years, we've established a lot of relationships. In my position as public health nutritionist, I've been in the schools working on wellness policies and a variety of initiatives that the state of Wisconsin has put out. So one of the things that the New Richmond School District does is they have a Healthy Kids Backpack program, which means that every Friday, kids in need get a backpack of food to help them have enough food for the weekend, since they aren't going to be receiving free school breakfast or lunch. And so we started thinking, wouldn't it be great if we could put some fresh produce in there? And so since 2018, we have been adding carrots. So the Master Gardeners grow 2 extra rows of carrots. They wash them, and we just bag them up individually. And this year we gave the most we ever have. That garden yielded 891 pounds, and we gave 118 pounds of carrots half of that individually bagged, and the rest went to the food service, and they are really excited to use it in their meals. So, so that's between public health, we had the master gardeners, then we brought in the school districts, and we also work very closely with the pantries, the food pantries, our St. Croix County WIC program, and UW Extension, the FoodWise, has come into, I've always personally wanted to do a garden program, and this year we did that. So again, in collaboration with the Master Gardeners, UW Extension, and our Public Health Department, which runs a program called Fit Families, which I've spoken to previous boards about. It's just really trying to work with the entire family unit to keep helping them to make healthy choices. Starting with the parents. So what we did with FoodWise from UW Extension is they came to the garden, and we had a story time in the garden where they read a book about packing a healthy picnic lunch. It's very interactive. The kids had food models, and they got to fill this picnic basket. Then they got to tour with the master gardener through the garden, sample. You may not think that's a big deal, but to get a 4-year-old to try a cherry tomato is a big deal sometimes. So they tasted, they smelled dill, they, had a pretty positive experience figuring out and learning where their food comes from, and that's not Walmart. This is where it comes from, this soil. They got to play and dig in the soil. They got to make a healthy snack out of some of the produce from the garden and some additions that we needed to add. And then they planted their own plant to take home with them so they could grow some things on their own. I just want to share, lastly, what are the challenges and benefits of our little community garden. This year, lack of rain was obviously a big one. They spent a lot more time watering. I spent a lot more time shutting off watering devices. And then deer. I live out in the country, and I have not seen anything near the amount of deer that I've seen in that garden. Several times when I'm leaving work, I've seen 4 or 5 deer just waiting for us all to leave the building so they can come in and pounce on our produce. So they tried various deterrents, and some of them worked, some not so much. Of course, the weeding, and I already mentioned I only had one taker on that, so they handled most of that. But really the benefits of the garden, anytime we can get fresh produce out to our community to try it, that's a win. And I asked the master gardeners what did they feel was some of the successes. And they said numerous times when they were out working in the garden, they would have people stop by and ask them questions, ask them different gardening, horticulture questions. They said that they really enjoyed working with the kids at that educational event. And I have to say that, here we had a story time with kids, but we also, I'm at the building every day, and I got stopped numerous times when I was bringing produce to our little cart that's in the lobby. And one time it was a senior who said, I just love this. I come every week because I don't want to go to the grocery store and buy one tomato. But you guys always have a tomato that I can take. Or there was another time, there was a mom with her kids, and she's like, this is so great to just get enough just to have a snack for these kids today. So kind of multi-age, meeting the needs of our community. And so it's a fun and I think a really positive experience for public health to be a part of. And that, I think the pictures here, that's me loading up. The gal on the right is the food service director at New Richmond Schools. So we had to load up her vehicle so she could distribute the carrots to all the different sites where the Happy Backpack program are packed. Any questions at all? All right, thanks. That's great.
Thank you very much.
What's that? Sure. Yep.
Well, first, thank you, Mr. Chair. First of all, I thought this was a great example of a community project that public health is involved with. And it's sometimes these kinds of projects get overlooked and don't get the attention that other things do. But it was I always thought it was a really unique arrangement to have this right next to the services center, and Teresa certainly responsible for making this successful. But I also wanted to mention Teresa is retiring December 8th. December 8th. After how many years? Almost 20 years here, and we're going to sorely miss her. Our hope is to recruit someone and have a little bit of overlap with Teresa, so she has some time to try and convey all that she knows to the new person coming in. But I just wanted to personally thank her for all of her work over the past 20 years, certainly for coming tonight and presenting on the community garden, but just thank you for everything, Teresa.
And come back and weed.
Yeah, right.
Next item is harm reduction. Educating boards and committees on preventive care.
Okay, I'll start us out, Mr. Chair. And sometimes about 5:30 in the evening, I have a hard time forming complete sentences. I'm going to do my best, though, because I think this is a topic that's important. It's something that I've been involved with in terms of the efforts that go into harm reduction over the past couple of decades. And I've asked Dr. Anwar and Julie Smith to help me on this presentation. I'll just sit here if it's all right instead of going to the podium. All right. I'll have to rely on Colleen for the slides here. Harm reduction is a term, as you might guess, that seeks to mitigate or reduce the risk of harm and death, primarily in the way this term is used, primarily with respect to substance use. And the definition that's up on the screen there is from SAMHSA, the Substance Abuse and Mental Health Services Administration. They're under the Department of Health and Human Services at the federal level, and they had a lot of information about harm reduction, so I just took some of the information from them to introduce the topic. And the reason I think it's important to bring it up, as a HHS department, we support these kinds of efforts very strongly because they are intended to prevent death from overdose and to mitigate the harms that people experience as a result of substance use. And I'll go into a little bit about this next slide. Well, let me think. Yeah, so I'll just go to this slide and then I won't get off track too much. But one of the more pressing issues right now with respect to harm reduction is the opioid epidemic that's sweeping across this country and others, especially with the introduction of fentanyl and other drugs that are like an animal tranquilizer called xylazine that's being introduced into the drug supply, but it's being mixed with all kinds of other drugs. So the user doesn't know what they're getting sometimes. Even if they're accustomed to using one particular drug, they may not know that it's laced with xylazine or fentanyl or one of the analogs of fentanyl. And fentanyl and xylazine are very potent drugs. It takes a tiny bit of those drugs to cause someone to overdose, especially if it's mixed in with something else like heroin or OxyContin or something of that nature. And a lot of these pills, a lot of these illicit drugs are sold over the internet so kids can buy them, not knowing what they're getting, right? So harm reduction is an effort to address some of those issues by ensuring that if a person is going to use drugs, which if they're addicted, they're probably going to use a drug even if there's a risk of harm. But by providing things like naloxone or Narcan, fentanyl test strips so they can test their own drugs to see if fentanyl is present in them. Clean needles, other clean paraphernalia, helps not just to keep them alive, but it also presents an opportunity. I know I'm not following the slides, but it presents an opportunity to provide something that might keep that person alive, and also the opportunity to provide information to them on how to get help. A lot of times these folks are people that don't engage with the healthcare system, so they're not really somebody we might come in contact with. So making these things available widely without any barriers for them getting access to Narcan, to fentanyl test strips, to other kinds of condoms, other kinds of things like clean needles that would prevent disease spread is important. It also helps to reduce stigma associated with drug use by saying we understand that this disease will compel you to use this drug. We want you to be safe if you do that, and we want you to know there's help if you want it. Right? So DHS has, well, I'll get into that later. So did we skip their slides? No, okay. So our current harm reduction efforts, as you have in front of you, you have some things that we're distributing right now that Shar ordered with grant monies that we had. One is the Deterra drug disposal kit in that little bag. The other in the pink or colored bag is Narcan kits. And then there's a little folded paper with a fentanyl test strip in there. And it's an example of the kinds of products that we can provide through HHS that are considered harm reduction. The controversy around this topic can be around, does this kind of effort incentivize or encourage drug use? So the counter to this is, aren't we just encouraging drug use by providing these types of products to the public? The research doesn't bear that out. The research doesn't indicate that by providing these kinds of products that we're somehow increasing drug use. There's a professor from Johns Hopkins Berman Institute of Bioethics, and I want to read his quote real quick. It's not on the slides, but I think it captures that controversy a little bit and explains it. So let me just read this, if you don't mind. Opponents sometimes argue that giving people sterile syringes, clean pipes, naloxone, a space to use drugs under supervision, etc., incentivizes drug use or leads to drug use. But people are going to use drugs whether they have these resources or not. And so withholding them doesn't prevent that use, it just makes it more dangerous. Making an activity more dangerous doesn't stop people who are committed to engaging in that activity. It just hurts and kills more of them. The idea here is to save lives in light of the epidemic, in light of the introduction of new drugs that are more lethal and that people don't even know they're taking. DHS has put out some grants where counties can apply for this money to buy vending machines. The vending machines would contain products like this, and then we could station them, if we were to apply for a grant like this, we could station them in places where people are likely to need these kinds of products, and where they're likely places where people who are unlikely to seek healthcare services might access them more easily. So that's the idea behind what we're trying to do. It's mainly to save lives, keep people alive so we can treat them, and make these things available with minimal barriers. But so I went way off script, but this is a public health approach to mitigating harm from a particular thing, in this case addiction. It's not a new strategy, but it's been framed as harm reduction and tailored to addiction primarily because of the unique nature of that disease that prevents people from getting help and compels them to do something that's not in their best interest. So trying to keep them alive, basically. Let me see how badly I missed the mark on all these things. I probably talked too much, and he's like, you talked about my slides. But so I think we'll just turn it over to Dr. Anwar from a physician's perspective to. to kind of do a more structured presentation. Thank you.
Thank you very much, Bob. I don't know if mine will have much more structure, but I like having discussions. So if anyone has any questions, feel free to interrupt me. I don't like giving one-way lectures. Never liked it in school. Still don't like it now. But we'll jump right in. So Bob asked me to give from a physician's perspective what harm reduction means. And there are many definitions of harm reduction, but the one that I like the most is an effective public health strategy and a compassionate approach to addressing the negative consequences of various health-related behaviors. And those health-related behaviors could be pretty much any disease. But the ones I'll focus on for our brief discussion here will be substance use, sexual activity, and self-harm. Its main goal is to minimize the harm associated with these behaviors rather than solely focusing on elimination. So to give you an analogy, for example, say you have an addiction, much easier to go in a stepwise approach and have an effective plan on recovering from that addiction than for just someone to tell you, go cold turkey one day. It could be smoking, it could be alcohol, it could be drugs, it could be pretty much anything. So from a physician's perspective, harm reduction is very important and has been shown in evidence-based studies to actually work, which is why I like it from a public health aspect as well. Thank you. There's many aspects we can delve into, but I'm going to focus on the ones that I found the most effective to communicate what a physician thinks when they think of harm reduction. The first and foremost is to be non-judgmental and to put the patient at the center of it. If we were to apply it to substance use, how can harm reduction help substance use? There's many ways it can do it. They can offer safer alternatives. They can offer access to clean needles, which we're doing, supervised injection facilities, opioid replacement therapies like methadone, as well as overdose prevention and education, as well as these things that we're doing right now with these bags here. The main goal is to reduce the negative health outcomes of drug use, and those can include things like infections, it can include overdoses, or the social stigma that comes with it. Regarding safer sex practices, there's many things that harm reduction can do. We can offer counseling for barrier contraceptives. We can regularly screen for STDs. We can even proactively prescribe pre-exposure prophylaxis if we think the patient, or if the patient thinks they're at higher risk of HIV conception. For mental health, many things that harm reduction can accomplish as well too. We can give patients alternatives to self-destructive behaviors. We can also make sure that they're given the appropriate counseling and therapies, and that we ensure they have access to when they ever have a crisis, which is the time they need it the most. For patient education, physicians play a key role along with harm reduction by educating patients on what things they need to watch out for, the plan that they create in gradually recovering from an addiction, and emergency plans on if they're going to relapse, what to do, who to call, where to go. The biggest one I want to stress on is reducing stigmatization. I feel all of us, consciously or subconsciously, we have an archetype or a stereotype on what an addicted person looks like, what someone with substance abuse, mental health disorder looks like. All we need to do is really look in the mirror, and that could be us one day. And we need to ask ourselves, if that is us one day, how can we feel comfortable in recovering? How can we feel free to ask for help without someone offering it to us? And then we can really put in perspective what harm reduction can do in the long term. Collaboration. It's not just the physician and the patient. It's really a whole team, or what I like to call a village, to really accomplish what we're trying to do. It involves social workers, it involves medical assistants, it involves hospitals, specialists. It even involves each of you in your seats here today. By voting and advocating for things like harm reduction, those initiatives can help put people like me in places where we can do the most good. So all of us really have a duty, and one day it could be us on the receiving end, and we would want all the resources we can to help recover. Monitoring and support. Harm reduction can really be a key to patients recovering in terms of monitoring how their recovering is going, whenever they have a relapse, what plan is in place, and also reiterating that regular check-ins and follow-ups are essential to recovery. This isn't a typo, but I put reducing stigmatization again because I do want to stress that that's one of the key aspects of harm reduction, removing that stigma that we each have. I even have it as well too. To summarize, the 2 key points I want you to take away from my brief slides here is that harm reduction is based on the principle that it's much more effective to work with individuals where they are rather than expecting them to immediately stop high-risk behaviors. By incorporating these harm reduction strategies into our practice, not just me and my practice, but also anyone involved in that healthcare team, we can better meet the needs of patients, our community, improve healthcare outcomes, and ultimately contribute to a more compassionate and comprehensive healthcare approach. And now I'll turn over to Julie.
Hello, everybody. I'll just give a little introduction. My name is Julie Smith. I am the director, owner, operator of Onyx Sober Living in St. Croix County, Polk County, Dunn County. My background, I'm an RN. I've been working in addiction medicine since 2016. I was working in a treatment facility in Minnesota where I was first introduced to harm reduction measures that they're doing there. And worked with them for about 3.5 years when my husband and I decided to open Sober Living in Wisconsin and putting my knowledge and skills to work here to try to help people recover from the struggles of addiction. So we have been in business since 2018. We now have 67 beds across the 3 counties. And we didn't start out with harm reduction measures in our homes. We have very firm boundaries on use in our homes and often discharge people for that to protect everybody else. But since then, about 3 years ago, we partnered with a group in St. Paul, and their whole mission is getting Narcan into sober living homes in Minnesota and Wisconsin. So we signed up with them. We have a monthly volunteer come and educate all of our residents on that. We have Narcan in all of our homes. And, part of the expectation for us is sobriety while you are in our homes. We have the expectation to attend meetings and work a recovery program, but not everybody is ready right away. And some people will hit a barrier while they're in the home and relapse and have to figure out. And so our job in sober living is to provide hope and to kind of plant those seeds so they know that there's a safe place to come back to. Now I have to look at my slides, hold on. And I think everybody here, we all know that it is a very powerful disease and there's many factors that can pull people out of recovery. And so some of what we did, we just started accepting medication-assisted treatment in our homes and follow them pretty closely when they're in the homes with that. But the main one was to get Narcan. In our region, we track the substances of choice for people coming in, and our 2 top substances are alcohol and methamphetamine. But opiates is on the rise, and like Bob said, it is fentanyl is laced into almost everything now. So we put Narcan in. Every month when we do our training, we ask how many people have been brought back with Narcan, and we have about 30% of our clients that Narcan has been used on and it has saved their life. Everybody in our homes is super grateful that we have it. They know that it is a life-saving measure. And while a lot of people believe that it just encourages drug use, we have not seen an increase in relapse rate since we put that in our homes. It is just talked about monthly and the training's provided. But the one thing we did do about a year ago is we saved a young man's life with Narcan in our home, got him to a safe place, made sure he was checked out in the ER. And without that, he probably would have died there. So we really, we really promote harm reduction because it will plant those seeds of hope, and that's what the most important part is when somebody's in early recovery. they most often come very, very hopeless. There is no way they're going to turn their life around, and we give them that opportunity. Turn it back to Bob.
Thank you both. Nicely done. All right, I'll read my slides. Most of the efforts that we've started through these ARPA-funded positions were intended to be targeting populations that generally don't access healthcare in usual way. Like these aren't folks that would generally walk into an office visit and meet with a therapist or something. They're folks that are encountered in the community through co-responders or through community-based case managers, peer specialists, recovery homes, or at the withdrawal management project at Western Wisconsin Health, where people end up in the emergency department and require some kind of, or really deserve some kind of intervention that would help them with their the disease of addiction. But we're also working with the criminal justice involved populations through the CJCC and really trying to, with Dr. Phil Ghali and the Behavioral Health Subcommittee of the CJCC, trying to look at our entire system of crisis care and early intervention care and seeing how we can better address those behavioral health needs, not just in the communities, but within the criminal justice system, because a lot of those folks end up in jail and don't have proper care or treatment for their disorders. We would like to pursue grants with, like I mentioned, with DHS that would allow us to purchase vending machines that would make these products available. We'd have to determine locations and things like that, but I think it would be a benefit to our community to have these kinds of things available so that people can access these products without the stigma or the fear of going to somebody and asking for them. Again, with the goal of keeping people alive. And then we'll continue to pursue these early intervention upstream efforts that we've started, not just through ARPA, but in other areas of HHS, Children's Services, ADRC. We always look at how do we reach people before they get ill, before they get into a crisis situation, so that we can intervene earlier, not just leading to better health for that person or that family, but to prevent the costs involved in treating them after they're sick, which is extensive. And it's part of what Faye's financial report reflects, is these kids in out-of-home care. About 70% of our families involved with CPS have some sort of addiction-related disorder that led to the out-of-home placement. So it's important that we reach families and kids and adults alike as early as possible in ways that, again, like Dr. Anwar said, meet them where they're at with respect to their illness. I want to point out that Cheryl Lopez, our deputy director, did a nice job of being creative with grant funds that we had, not creative in a bad way, but creative in spending them on these kinds of products like Deterra, these drug disposal kits, Narcan, and fentanyl test strips. It's under the state opioid response grant that we had for last year, and we had additional monies left that we're able to spend on this for this use. And we have a bunch of these drug disposal kits especially. Now, the Narcan supply is a little thin right now, so when we can get more from the state, we will. But we have lots of these drug disposal kits that we can distribute, and she has been distributing widely to police departments, Grace Place, the homeless shelter, recovery housing, and wherever they're needed. So we've started to do that and can plan to continue to do that again. Hopefully this topic and this discussion or this presentation kind of gives you a better sense of why we're pursuing this sort of thing, and it's really just to save lives and prevent people from ending up in hospitals and jails and other places, instead getting help. The last thing I'll say is if you watched or were at the mental health symposium that we had last spring, the gist of that symposium was to look at addiction through the lens of healthcare. And if you think about it, we don't treat behavioral health conditions the same way that we treat physical health problems. If you break your arm, you go to a doctor, you get treatment, you get better. But behavioral health conditions are much different. They're much more nuanced. They're much, especially addiction, well, pointing to addiction. It's a very counterintuitive disease where people do things that they know are not in their best interest, that harm them. And so approaching that from a healthcare perspective means that looking at the disease as a medical condition that requires specific intervention strategies, you know. And as a community, as a county, if we can get better at recognizing addiction and mental health disorders as in parity with other health conditions, we can start to treat them more effectively, fund the treatment of them more effectively, and make a substantial difference, make a meaningful difference in the way that recovery takes place in our communities, and build community support around these folks. When they get better, they become taxpayers and productive members of society, and they also give back to society more often than not tenfold. So you have a potential group of people that you can help to get better that will then give back to the community. And that's the goal behind all of this. So if there are any questions for me, I assume Dr. Anwar or Julie, please ask.
Any questions?
I had one.
Go ahead.
So we have the fentanyl test strips. I remember at the county's association meeting, there were talk about the xylazine, like you can't use that same test strip for xylazine, right?
Xylazine's not an opioid, it's an animal tranquilizer. And xylazine test strips have been classified as drug paraphernalia through current state law. So there's a bill coming forward in the near future that will redesignate xylazine test strips not as drug paraphernalia, but as in the same light as fentanyl test strips. And any future test strips for future drugs that come out will not be classified as drug paraphernalia. That's my understanding of the bill. The language hasn't been written yet, but yeah, it's a good point.
I have many thoughts on this, but I'll stick to a few. I will never personally, ever, and I don't say that rarely, support the county being responsible for any distribution of needles. I understand that it could prevent spread diseases, but to me, it'd be like providing a diabetic with Little Debbie's to make sure they don't get salmonella. Like, it's kind of, and you might think that's outrageous. That's kind of where I stand on that. And the same with safe injection sites. I will never support those in our county. I'm just going to say that flat out right now. To me, it leads to, from what I've seen in other places in the country, it leads to a concentration of drug use in those areas. And even if the number doesn't change, I don't want a bulk concentration of drug users in a city block or one small area. That's just not something I would ever support. As far as the drug deactivation systems and fentanyl test kits and Narcan, I am fully in support of all those things. Those are life-saving measures. This will make it this will make it so there are less drugs available for people to use. 100% in support of that, but I will never support something that makes drug use easier. That's kind of my thought on that.
I understand probably Western Wisconsin hospitals are doing harm reduction. Are other area hospitals do the same thing? Are they all on board with harm reduction, like Health Partners or any other?
They are in different ways. The bigger systems are a bit more involved. If you look into the cities, I know that's not in Wisconsin, but United Regions, they have more efforts, but they're serving a much larger population and much more diverse.
Well, I'm thinking St. Croix County right now.
I'd have to get back to you on that. I do work at other hospitals like Osceola and Spooner Health. That's not in St. Croix County, but New Richmond is, yeah. I'd have to get back to you on that, on their specific efforts. I just haven't worked with them that closely to know.
I can pop in on that a little bit. Since a lot of my men go to Westfields for care, they do provide some harm reduction efforts. They are providing some medication-assisted treatment out of that clinic. And I know they've been very strong advocates of Narcan for sure.
And is there ample counseling available in St. Croix County for people who need it?
I can tell you at Western Wisconsin Health, we have a great need for counseling, and our appointments are pushed out weeks, sometimes months. So there is a great need for counseling.
Yeah, we're seeing the same thing at Onyx too. Somebody was seeking psych services and it was a 6-month wait.
6 months could be too late.
Mm-hmm.
Bob?
Yeah, I just wanted to respond to Supervisor Anderson's comment, and we're not suggesting that we're going to do needle exchange programs or have safe injection sites, but it's an example of harm reduction that is in place in some places. But I understand it's very controversial. It's not something we would just do without, support from communities. So.
Yeah, I guess I just wanted to make clear before we got too far that was kind of where I stood on that. I mean, like I said, I'm fully in favor of the fentanyl test strips, the deactivation systems, the Narcan. I just saw the and others, and I wanted to clarify what I expected or hoped that would be.
Our main objective, I think, would be to distribute these products that you have in front of you as widely as we can to those that might need them. So that the vending machines were even sort of controversial among different counties. So I wanted to introduce this topic to sort of see to gauge your support for if we were to apply for a grant like that. I don't want to do that without the board's support for something like that.
Yeah, I guess I get the hesitation around vending machines because you get, depending on where they are, you get the questions that are, if a 4-year-old might see it and, oh, what is that for? And I don't know that that's something that I would want, or that I get there's a balancing act, and that's kind of what we were here to do, but the general public to be exposed to on a daily basis. So I can kind of, I'm so on that. I could be convinced either way. Or I haven't made up my mind yet on that. I don't know enough, but I appreciate the clarification. Thank you.
I understand the harm reduction aspects very well. Have we linked arms in a law, with the sheriff, on the crackdown on drugs coming across the border, being available? What do we do about that stage of it? I mean, we can treat all day long and be kind and foster and give therapy, but when do we just say no to drugs? When do we just crack down and not allow that, that saturation of it into the county? And I know it's not easy, and I know that we get it through very different means. But there has to be the before piece to this aftercare piece. And that's my concern. We can continue to just vomit money and programs and all that stuff, but until we say no and just crack down and be that county that says, you get caught here, there are repercussions that are bigger than anywhere else. Go somewhere else and get this county healthy. Sorry.
So one of the workshops at the counties association was really sort of about addressing that. It was a very collaborative effort between law enforcement and HHS, and it involved a declaration of a public health emergency related to fentanyl within their county. And then it became a dashboard where you could monitor where drug activity was, and it wasn't for public consumption, it was for law enforcement and for HHS to really identify where they might want to put resources to get people help and to do punitive things as well. But I think this is one of those problems that affects multiple agencies in the county, and breaking down the silos is key to starting to come up with solutions.
One of the things I would say that's difficult to control around that is the internet, and people can order these pills from anywhere. And one of my main concerns is around kids. Ordering something off the internet, overdosing, and not having any method of reversing that overdose. So while you don't want to project, I understand you don't want to project that we are accepting of drug use per se, but at the same time, you have people with an access to those kinds of drugs through the internet that you can't control, and at least not yet, we haven't been able to. So that's a method of that's something that police couldn't necessarily fight against right now. So it's trying to keep people safe when they do things like this, so that they don't die, especially thinking about kids ordering this stuff. So
just going to give you a real world example. My wife works at a package handler in the county, and one of her loaders handled a package that broke open and happened to have concentrated THC in it. And he touched his eyeball or wherever, I don't know, he touched his eyelid or what, and then he went into anaphylactic shock basically from having this concentrated drug, and they saved him with Narcan. So I guess I can see the real world application. Where are we trying to distribute these would be my next question, and then what would be, have we seen a lot of use of these products, I guess would be my last one.
If you don't mind coming up and just kind of, Char's been really involved in not just promoting the distribution of this, but responding to requests for these kinds of things. So she'd probably give us a better idea of who's.
So the Narcan actually, I think 2020, was bad, right? And public health, it was given to public health as a, they were supposed to distribute it, and that didn't last very long because they got real busy. And so we took it over in behavioral health, really as a harm reduction, just trying to, we had a bunch of Narcan, how can we use it? And we were still part of the Narcan Direct program. My first round of trying to engage schools and different entities was like, yeah, we don't need that here, until they needed it there. And then I got contacted from the school and said, holy cow, we need this in the school. So last year I trained all of the nurses in the district for New Richmond, and they put Narcan in all of their AEDs. Baldwin School District reached out. They actually had their administrators, their counselors, and their nursing staff all trained. And it just became, it really wasn't an issue till all of a sudden it became an issue for everybody. So we actually ran out of Narcan, and the state ran out of Narcan, and we just had those opioid settlement dollars, and I could only find 120 boxes of doses of Narcan that we could purchase, and we had more money to purchase some, but there just wasn't any available, or they were limiting how many we could purchase at a time. So for certain, the Narcan, I believe, is very widely accepted as something that is necessary. How often is it being used? I can't give you a solid on that, but I know for certain that we have overdoses that are occurring all the time in our, whether they're being reported in the hospital or not. We hopefully have gotten enough of this out that we were able to at least save some lives. The Deterra is real new. This is, I have a lot more of this. So this is actually something that is very easy to use. This one in particular takes 45 pills. You can fill it with water, you shake it up 30 seconds, and it deactivates. There are some drugs that it doesn't work on. If you scan the code on here, it'll give you the directions. I gotta think all the places that we brought it. Just today we brought it to Western Wisconsin Health, River Falls Hospital, River Falls Police Department, the New Richmond Police Department got some, Roberts Police Department. We brought some to as many. I still have 8,000 left, so but we have enough to distribute widely because this is a super easy way to take all sorts of drugs off the table. Kids don't know what they're taking, and if there's something in a medicine cabinet, whether they're taking it inadvertently or not, you can just get rid of it. I know Kelly Ingen, the public health administrator, said, man, I have had my grandma's meds around because I keep forgetting to bring them in. And so, how many of those do you have in the medicine? Mine's full of things that we don't need anymore. And then the fentanyl test strips. So they were a little bit, so the state, these were also bought with our SOAR grant, our spend down. The state had originally said, we got this program, how many do you want? They sent us some, they didn't send us any directions. We waited a while, we got the directions. You needed a PhD to actually decipher how to use them. Then the state came out with some easier directions, which are actually attached here. We distributed those mostly to the treatment programming within the county. Also, Justice Services got probably half of what we had. I just handed over probably 50 to Shelby and Justice Services today, so they're well stocked again. They also, Narcan is something that they distribute to almost every one of their clients, or many of their clients that are coming through as well. So those are the efforts, the local efforts we have, and honestly, we've educated just at different meetings and the Knights of Columbus. I mean, we've had a lot of different requests for just coming in and tell us about it, because it's something that people hear about on the news, but they don't really know what it is. I don't know if that answered the question, but.
We even they needed Narcan in the courtroom upstairs. So now they put Narcan with the AEDs here.
Yeah, thank you for saying that, because I kind of forgot about that. That was kind of a big deal. They saved a gentleman in the court. So, and again, I was here, we were training staff, and it didn't have context or meaning, because there really wasn't something that had happened. And now that it's happened, it's risen awareness. So we too have it in all of our AEDs. They're in the AEDs here. Like I said, the schools have them in the AEDs. I know that one of our staff was going to another school yesterday to train too. So we have a team of people who are trained to do the trainings. The Narcan's real low on supply right now, but we certainly have enough to stick in people's AEDs for certain. We also did the National Night Out, and it was a really good opportunity to educate folks, because there was like three different schools of thought. One is like, well, we're not those kind of people and we don't need that. The other is, hey, I heard about that, tell me more. And the other was, I've been trained, I own a business up there, can I have some for my business? And so it was really interesting to have those perspectives. and the opportunity to just kind of educate on that. And one couple went by and I said, you know, do you need some? Oh, we don't need that. I said, do you have any college kids in your life? Oh, yes. And then came back with her grandson, and she's like, you need 2.
I had one other question, which, do these expire? And I might have asked you this before, but I always like to ask the question on camera.
They
Because then
actually,
somebody else knows.
they do. So the manufacturer, I think it's 2-year shelf life, but it loses its effectiveness, but it doesn't go bad. Like it will maybe not be as good as the first one, but I get it, you know, it's still gonna better than 1,000%. Yeah.
Best buy date, like on your milk?
Yes. Well, not like milk. It's probably better than milk. Sour cream, maybe.
Could I just add that if someone is unconscious and you administer Narcan, it's not going to hurt them if they didn't overdose. So Dr. Anwar could certainly speak more to the chemistry of the medicine, but my understanding is it's really a safe way to try and revive someone, not knowing whether or not they overdosed. The other thing I was just going to mention when Char was talking was the drug disposal kits might be something that the ADRC could distribute too for seniors that have lots of medication sitting around. Maybe they don't need any more. And who knows who may be coming in and out of their house that might look through their medicine cabinets or something. So these are very, I think, easy ways to just destroy drugs that aren't being used anymore.
And if anybody needs any of these things, they're available either at the front desk. Actually, all of it is available at the front desk. Front desk staff have also been trained on how to train people, but they have the Daterra just sitting right on the counter available for people to come in and grab some. We also have bigger ones, so these are the 45s. There's smaller ones, there's 15s. I gave those to the law enforcement just because it's easier and not so bulky, and if they have them with them. And there's 90s. There's bags a little bit bigger, so if there's bigger chunks to dispose.
Any other questions? Go ahead, Deb.
I just wanted to make a comment. I wouldn't support giving free needles out either, or sterile needles either. I think we're a long ways from that, but I think this is a great program. I mean, you can't help anyone if they're dead, so it just makes sense. And then I had a question about the fentanyl strips. Do people, I mean, are people that use or addicts, are they aware of the dangers? I mean, will they use the fentanyl strip, or I mean, that would be my question. Okay.
Yep. Yes. Yes. If we make it available, they will be used. They don't want to use fentanyl if that's not their intended.
We had at the Public Protection Judiciary Committee that discussion had come up. Medical examiner was talking about the fentanyl deaths, and the sheriff was talking about the increasing positive tests for the fentanyl. And one of the questions was, well, does the people know that they're taking fentanyl? He said, no, they're actually sometimes surprised when we say, well, you tested positive for fentanyl. It's like, well, I was taking drugs, but that's not the one I wanted to take. Right. So they are surprised. So that's where I think these test strips are probably going to be helpful.
Well, thank you very much for all the information today. Thank you. Any announcements or correspondence? Oh, I can't read either. Request for future agenda items? Okay. Announcements or correspondence?
I just had one, Mr. Chair. It was that there was a legislative advocacy event in Madison today. One of the topics was mental health crisis funding, and the other was around expanding the definition of kinship care in children's services. Kristen Newton went on behalf of HHS, and Supervisor Osnes is there today as well, or was there today. But both of those topics, Kristen and I discussed in some depth And she's well-versed in it anyway, but she was a good representative of our department, I think, today, and went there and did that. So that's it for me, yeah.
Very good. Stated next meeting is scheduled for November 15th, and I'll adjourn the meeting. Thank you, everyone.